Hello, my friends and my colleagues and my fans everywhere. Today I will talk about acute chest pain. In continuation of my series of presentations about pain as an important presenting complaint or symptom in clinical practice. Acute chest pain is a very common clinical condition in everyday medical practice. Acute chest pain can be either related to chest trauma, whether localized or as part of a whole body trauma, as happens in catastrophes and in crash injuries and in road traffic accidents and other forms of trauma, whether it is blunt trauma or sharp trauma. So traumatic chest pain is one class of causes of chest pain, and it is usually related more to the surgical specialties, because in chest trauma, a cardiothoracic surgeon and a neurosurgeon and maybe even orthopedic surgeon are all surgical disciplines involved in the management of chest trauma and body trauma, a traumatology team. Let me now focus on the non-traumatic causes of acute chest pain, non-traumatic causes of acute chest pain or medical causes of acute chest pain. The first and the most important and the most serious and most common cause of acute chest pain is that related to coronary artery disease, or what we call coronary syndromes. The chronic type of coronary syndrome is angina or angina pectoris. So angina presents commonly with recurrent attacks of chest pain, more commonly related to effort or exercise, and they are relieved by rest, and they usually last for a few to several minutes, and usually triggered, as I mentioned, by exercise and relieved by rest. And this chest pain is constricting or pressure or compressing, and it radiates to the left arm or to the left hand, and sometimes up to the neck, and sometimes to the interscapular region, and sometimes even up to an inflamed tooth in the head. And sometimes it's referred to the epigastrium, as I mentioned, among the causes of acute abdominal pain. Sometimes presents with acute upper abdominal pain also, especially if the ischemia of the heart happens in relation to the inferior surface of the heart. It will be referred to the upper abdomen or the epigastrium. So cardiac ischemia related to coronary artery disease or angina is an important cause of acute chest pain, but this is more commonly related to chronic and recurrent or subacute and recurrent chest pain. Then we come to the more important, more serious conditions of acute chest pain, also related to coronary circulation, and these are the acute coronary syndromes, the unstable angina and the acute MI or the heart attack. The acute MI is the ultimate end result of severe coronary occlusion, usually related to obstruction of a previously occluded artery, that is what we call atherothrombotic occlusive acute MI. And this is one of the most important, serious, and even maybe life-threatening cause of acute chest pain, acute MI. And usually they present with central or precordial pain, central chest pain or precordial pain, which is sharp and which might also be referred to the shoulder, left shoulder, or to the down to the left arm and left hand, and sometimes up to the neck, or refer to the jaw, or to the angle of the mouth, or to the inflamed tooth, and sometimes also refer to the interscapular, but sometimes refer to the epigastrium or the upper abdomen. So acute MI. The most common cause of acute MI is coronary atherothrombosis, of course. When there is a complete occlusion of one of the branches of the coronary arteries, the right coronary or the left coronary, that involving most commonly the left anterior descending artery, or the circumflex artery which supply the left ventricle, so they might produce left ventricular infarction, which is the commonest form of myocardial infarction. It's most commonly in the left ventricle. Less commonly it affects the right ventricle or the inferior surface of the heart. In all of these types of myocardial infarction due to acute coronary occlusion, we get acute chest pain, and the chest pain might be associated with other, and here in acute MI the pain may occur even at rest. It's not related to effort or exertion or exercise, as what happens in the milder forms of angina or the chronic form of coronary insufficiency. Here we get the MI at rest, and we get the chest pain while the patient even at rest, not doing any. It might attack the patient suddenly and acutely, even when he is or she is at rest, not doing any exercise. That's why we call it heart attack, because it suddenly attacks, acutely attacks the individual, even at rest, and produce acute chest pain and severe chest pain. Sometimes the pain of MI is painless, and this is what we call painless MI, and this happens in some conditions, like what happens in MI in shocked patients, for example, MI in patients with autonomic neuropathy affecting the autonomic nerves of the heart, like in diabetic patients. Diabetic patients commonly experience MI without pain, and so painless MI, that is MI or heart attack without chest pain, happens in diabetic patients, especially patients with old diabetes who are chronic diabetics for a long time, long-standing and uncontrolled hyperglycemia. They get complicated with autonomic neuropathy affecting the autonomic nerves of the heart. So when they get myocardial infarction, it happens that it might be painless, without pain. There is no chest pain. We call it painless MI. So diabetics, chronic diabetics who are uncontrolled hyperglycemia over a long period of time. Another cause of painless infarction is patients with myxedema, which is thyroid failure. Also, in such patients, they might experience MI, acute MI, which is a known complication of uncontrolled hypothyroidism or myxedema, and it is a common manifestation of myxedema heart disease, which also involve the coronary circulation and might be ultimately complicated with acute MI. This MI may also be painless MI. As I mentioned, in patients also with shock, we might get MI, or patients under the effect of drugs, especially narcotics, they might also get MI without pain. So these are among some of the important causes of painless MI. But the classic MI, it always presents with acute severe chest pain, with or without other cardiac symptoms like shortness of breath, which might be related to pulmonary congestion and pulmonary edema. Of course, if the MI is complicated by left ventricular failure and the pulmonary edema, the patient will get severe dyspnea at rest in addition to the chest pain. So beware of dyspnea with chest pain. Might be or may refer to or might indicate a pulmonary congestion and edema complicating acute MI. Dangerous to chest pain and dyspnea at rest. Breathlessness, severe breathlessness and shortness of breathing while the patient is at rest. These are devastating signs denoting a heart attack. And then we, plus of course the other manifestations of acute MI, like maybe arrhythmias, which is a common complication, especially extrastalls, and then maybe atrial fibrillation, maybe VF in severe massive myocardial infarction, which also might induce cardiac arrest and sudden death. So different types of arrhythmias, supraventricular, ventricular, might complicate MI and present with irregular heartbeats and cardiac arrest, in addition to the chest pain and to the shortness of breathing. Up to the occurrence of cardiogenic shock in acute massive myocardial infarction, cardiogenic shock. So MI is an important cause of acute chest pain. Then I come to other cardiac cause of chest pain, other than the angina and the acute MI. We have aortic dissection. Aortic dissection is a very important differential diagnosis of acute MI in patients presenting with acute chest pain. But and we have to always put the most important differential diagnosis of acute MI causing acute chest pain is aortic dissection, acute aortic dissection, affecting the ascending aorta or the arch of the aorta or the descending thoracic aorta. It presents with also chest pain, but the chest pain here is more referred to the interscapular region. So think about aortic dissection, especially in anterior chest pain with interscapular referral, or patients with severe pain also in the interscapular region. This might indicate dissecting aortic arch and descending thoracic aorta, interscapular pain. And this pain is usually tearing in nature, not compressing in nature or pressure like the pain of MI. It is the pain of aortic dissection is tearing in nature or stepping in nature. Stepping and tearing pain زي ما يكون حاجة بتقطع. This tearing pain and sharp stepping pain might indicate that the source of acute chest pain is aortic dissection. So aortic dissection is important differential diagnosis. Then also there might be this might be associated, especially aortic dissection, with changes in blood pressure, and these changes in blood pressure are common presentations of aortic dissection together with the chest pain, the anterior chest pain and the interscapular chest pain, which is tearing or stepping in nature, and this also might be referred to the upper abdomen. Severe hypertension or hypotension are common complications of aortic dissection. So either hypertension or hypotension, they might contribute or present or the presenting symptoms. Hypertension, if severe, may be the cause of aortic dissection, or also may be a reaction to the aortic dissection. So it may be cause or effect of the aortic dissection. Or on the contrary, if there is severe, rapidly progressing dissection of the aorta, the patient might get hypotension. So rapid swings in blood pressure with severe hypertension or hypotension may be associated manifestations or clinical manifestations associated with chest pain in patients with aortic dissection. The most important here is to do an ECG. ECG will differentiate MI from, in most of the cases, and the audition. If it is MI, there will be the classical changes of acute cardiac ischemia in the ECG, the pathological cues, the ST segment elevation, the risk-curved ST segment, and also the T-wave changes, characteristic of cardiac injury and necrosis, which happen pathologically in patients with acute MI. But in aortic dissection, there will usually not be such changes of classical changes of MI in the ECG. Also, important to do cardiac enzymes when they are elevated, and also troponin I and troponin H, which indicate evolving myocardial infarction. So measurement of cardiac enzymes and troponin, and following the ECG changes suggestive of acute coronary syndrome, and doing serial ECGs is very important. Don't do single ECG. Single ECG will not judge. You have to do serial ECGs, maybe every half an hour or every hour over 6 to 8 hours. You have to do serial ECG tracings and recordings in order to, or even to put the patient on monitor in order to detect an evolving myocardial infarction, because the first initial ECG may show nothing, so this does not exclude acute MI. And then to do also cardiac enzymes and troponin, cardiac troponin. This will differentiate MI from aortic dissection. To diagnose aortic dissection, you might need aortography, you might need CT with aortic angiography, CT of the chest. It will detect also, and this is very important, CT with angio and CT with aortography for diagnosis of aortic dissection involving the thoracic aorta. So this is how to differentiate MI by ECG, by chest X-ray. Also, chest X-ray sometimes give clues, widening of the mediastinum, happens in patients with widening of the mediastinum due to dilated aorta in aortic dissection, effects on the heart and heart failure, and cardiac hypertrophy in patients with MI. So chest X-ray give clues about many things and help in detection of the underlying condition or its complications. If the patient is developing edema in MI, there will be, of course, evidence of pulmonary edema in the chest X-ray and opacification in the lung fields. Either partial or diffuse opacification of pulmonary edema. If the patient has aortic problem, which is commonly associated with aortic dissection, we might find a mediastinal shadow or broad mediastinum or wide mediastinum. And then we have to proceed to do a CT with angio for a more accurate detection of the aortic dissection. So all of these investigations together, the ECG, the X-ray, the CT, they can, the angiography, the interventional radiology, they can help in to reach the definitive diagnosis and to differentiate acute MI from aortic dissection. At the end, both patients should be put under monitoring, continuous cardiac monitoring in an intensive care unit. So don't ignore acute chest pain because this might be related to acute MI or to acute aortic dissection. These are among the most important, serious, life-threatening causes of acute chest pain. Thanks so much. I will continue talking about other causes of chest pain in my next episodes.